Welcome everyone, good afternoon. The second day, we've all just come back from the second plenary sessions where we've heard some very interesting results again from nice performed randomized controlled trials. My name is Robin Lemmens. I'm joined here by Silke Wolter.
Hello everybody, we are here with three experts on ICH, Charlotte Cordonnier from the University of Lille, Thorsten Steiner from the University of Frankfurt and Rustam Al-Shai Salman from the University of Edinburgh. And we would like to discuss this very exciting session we've just visited. Shall we start with the UK PDS trial? So that was an interesting trial assessing the effect of randomization to tight or less tight blood pressure control and intensive blood glucose control. They treated their patients for 10 years and collected data on incidence of stroke and dementia after 44 years. What are your thoughts on this?
Well, I think it's an incredible amount of work and quite an original approach because making the best of data collected in the 80s in 2020. However, I'm not sure we can make anything in clinical practice from what we heard. I think the approach is interesting, but I mean, what would be your take-home message about that?
We also all like to have short messages. I think the trial was at least not positive. I'm not sure about whether we can use the results because we have such a long observation time and many things happen in between. So I don't know what we can take from that.
And what do you think about this treatment period of only 10 years? Because people are getting older, participants are getting older, and more likely their risk factors increase, so they need more tighter control later on in their lives. And as far as I've understood, they've stopped the treatment then. So
yeah, it could also be counterproductive if you do not look at it carefully because of course when we deal with a patient with a risk of stroke we insist on the daily management of risk factors, and what you did 30 years before may have an impact maybe on the burden of chronic lesion and on the way you'll be able to improve after a stroke, but I don't think it has such an impact on preventing one single event.
So how would you even, thinking about that, and I'm thinking about getting funding for trials, how would you nowadays design such a trial? Do you think this would be feasible to have it properly designed and funded, or what are your thoughts?
Yeah, I mean, I think in defence of this trial and the extended follow-up, this is an extremely cost-effective, cheap way of looking at long-term follow-up.
That's true.
And I think if you look at the left-hand end of the survival curves, where you see separation between the curves, it's showing you the benefit that UK PDS did find in some of the comparisons early on. But what's difficult as fewer and fewer patients remain under follow-up is that the right-hand end of a Kaplan-Meier curve is quite unreliable. The important thing though, Robin, is that we know that routinely collected data can be accurate for some of our major stroke outcomes. And I think it's really novel that this trial looked at dementia as an outcome, ascertained both by investigator reports and routinely collected data. So it seems to me that the results are quite valid. It's just that we need to look for interventions that might have a very durable treatment effect, trialed in enormous numbers of people. And let's remember that these trials were that the trial included only a few hundred. So let's look at all the other trials that have massive numbers of people and are following them up for events that can be reliably collected by routine data. And with maybe €100,000 more, we can look perhaps with greater precision durability of treatment effects. So I love this approach.
Yeah, because that's probably the way we should go if we really want to collect data for such a long time interval. It's not possible to get that funded by having research coordinators collect all that information. So routinely collected data should be used for such kind of treatment.
Yeah, I mean, compared to 44 years of site visits.
And also it's probably where Europe and the European Stroke Organization makes sense, because you probably cannot address this issue just one country by itself. It's really
that's
we
very
all
true.
have an administrative linkage that are
Yeah.
now available. We just don't really know how to do it in our
Yeah.
own country and then try to merge
To mer-
this approach at a European level.
So,
Yeah.
Rossum, just one question to you. What you think about that the population might have changed in between? For example, we heard during the talk, we heard that the body mass index has changed over time, saying that people are more heavyweight now than they were 44 years ago. How do we deal with that?
Yeah, I mean, obviously the background characteristics of the population and characteristics of our everyday care do change over time. It's always the problem we have with trials, isn't it? Shall we repeat a trial that was done 10 years ago again now to check it's valid? But I think it's probably about whether the treatment effect is generalizable to our current population. Is the difference that's observed valid? Because I think the characteristics of the patients may change their background level of risk, but I don't know how much that's actually going to affect the relative treatment effect. It might affect the absolute benefit, but
Yeah.
maybe not
Yeah.
necessarily
Yeah.
the relative.
Yeah, that's a good point. Yes.
So,
Yeah.
but we heard many more data
Yes.
today. So we want to talk a little bit about the ICH trials as well. So one was focused on surgery, looking at not so many patients. Well, for a surgery trial, probably a lot of patients. But then the other trial looked at thousands of patients with an intervention. So what are your initial thoughts about the results of these studies? And maybe we can start with the surgical intervention. Thorsten.
Well, first of all, it's very interesting and nice to have the first and today actually 2 positive trials on ICH. There is no doubt about that. It was a lot of data we have seen. Referring, for example, to the inclusion criteria, it seems to be, or it would need that we put this in relation to other trials and results from other trials we know. And because they had different inclusion criteria, for example, we have patients in there who had a high amount of interventricular hemorrhage. We have patients in there who were included with a Glasgow Coma score from
5 to 14.
5 to 14,
Yeah.
which is quite a
broad range.
broad range compared to what we regard when we do recommendations and we speak about how patients do develop over time and how we react on deterioration.
Yeah. I think the way I see surgery, probably not with this trial, but I don't only see surgery just as a life-saving measure or just on people who deteriorate. I probably see surgery in the way that you have to prevent secondary injury due to the blood that is in the brain and that shouldn't be there. So we'll probably go towards less invasive strategies just dedicated to take off the blood, whatever the clinical state is, in the next few years. I mean, that's my...
What was also quite interesting that the group with deep ICH, basal ganglia ICH, that was then terminated because they actually didn't do very well with the surgery. So what do you think? What could be the reason for that? Is it just a trauma caused by the surgery itself, or what do we do with these patients? I suppose that no one of you would now drag a patient into the theatre only based on these results.
Yeah, probably they call it mini-invasive, but it's
Yeah.
still surgery.
Yeah.
So you still have to go into the brain, and they probably have to develop less invasive strategies that will be just dedicated to the deep ones.
Yeah, I think we need to look at the device. And the device is not just a small tube you
Yes,
insert
it's
in
quite
there.
a big one.
You first start with inserting something which has a diameter of 1 centimeter, something like that, if I'm not mistaken, and then you start with suction,
And these shear forces can, of course, cause
Yeah.
damage in the surrounding area.
So we
What do you
heard
think?
many more, I mean, over the years we've heard more trials, results being presented about surgical interventions. If you now compare these results to what we already know. So what are your initial thoughts? Of course, not knowing all of the data because it's just been presented as a short presentation. You don't have all the insights, but what's your idea about that?
Well, I mean, I think we've been feeling optimistic about minimally invasive surgery for a few years. And there was a very nice systematic review and meta-analysis in Annals of Neurology done by Lottie Sondag and others in the Netherlands, dividing the trials that have been done of surgery into those that used craniotomy as a technique and those that used minimally invasive surgery. And that already showed us that there's promise, a bit of heterogeneity, but there's promise amongst the minimally invasive surgery trials. So I think this trial now arrives on that background. I think, so for me, I'm not quite as surprised and elated as some people about the result, because I was already feeling optimistic about minimally invasive surgery. The question for me is whether this very small trial with an arm with a subgroup that was dropped, as Silke says, early, needs to be replicated for us to be sure, because let's remember it's still a small trial. So very optimistic. I feel great, but I would like it to be replicated. And I'm really wondering whether my surgical colleagues are going to randomise now, or use this, or continue their nihilistic approach to intracerebral hemorrhage.
Yeah, I think it's probably, I mean, the excitement about a new approach brings two important things to plan in the future, next trial. So keep in mind the scientific uncertainties about that, but also being ready to organize our pathway care to have this option. And even though we had a huge trial that would be positive, I don't think that worldwide we would be ready to implement such an approach. And I keep seeing ICH as a medical emergency, and we as neurologists have to organize things, or stroke specialists have to organize things so that there might be in the future a surgical approach. We are not there yet, but we have to be ready in terms of the way we see things and we interact with neuroscience people.
And that is a good keyword, I would say.
Well, and I think it also really nicely connects, I think, the findings of the second trial, which also ended with that statement, I think, that ICH is a medical urgency. Yeah. And so then also maybe talking a little bit about that trial, which did not include a couple of hundreds, but thousands of patients worldwide. So what were your initial thoughts, Preston, then, when that was shown?
So I was extremely enthusiastic because the burden, the majority of the burden of intracerebral hemorrhage is borne by low middle income countries, and that's where Interact 3 happened. Second, it was enormous, and we want big hemorrhage trials. We've had very few of them in the past. And third, it used an intriguing design of an intervention that we want to use in everyday practice, organised care for our patients with intracerebral hemorrhage, and we want all the participants in a trial to use it. So the way to do that is a step wedge trial where sites are gradually randomised in blocks to introduce the intervention. So everybody got the intervention, really patient-centred approach. And then finally, it addressed the problem with these bundles of care where we can't do them individually randomised and give Charlotte one type of care and Silke another. We have to randomise hospitals. But those trials are big and dirty. So despite all of that, they've got a remarkably consistent result on a very important outcome. And Interact 3 was the trial that increased my heart rate today.
Yeah, I think it's of great practical relevance, because I think it will change the way how ICH will be treated from now on, I guess, because nobody can just disregard the results, which is basically telling us, don't ignore ICH patients, keep the pressure low, keep the temperature in normal ranges and the glucose in normal ranges, not talking about reversal. And I think that has a major impact on daily practice.
But I think that also emphasizes again the importance of stroke units.
Yeah.
And I think that was also mentioned at the end of this presentation. Yeah. Don't leave them in the emergency room. Take them to the specialized wards. Yeah.
And I think you can see the practical impact by when you looked at the curves. You didn't see so much difference in between the groups when you look at glucose and when you look at temperature.
Yeah, just blood pressure.
Yeah.
The only thing is the blood pressure, and my belief is that it's a blood pressure trial, but all what went wrong in those trials we had before meaning controlling all the other confounders that went right here. And this is probably one of the reasons why we see this result.
Well, I want to thank all the three of you for your insights so quickly after being presented the results. And so for the next 50 minutes, we'll be talking about the opening of today's plenary session, which was about sustainability. But thanks very much.
Thank you very much.
Pleasure.
Thank you.